We are recording the session. The recording just started up, and we will be posting that on our Moodle asynchronous learning platform as well. So if you have any questions about that, contact myself or Michelle Widener, and we can get you connected with that for any of our PEDx or any of our other sessions for AHI or any of our other sessions. So we do offer CME, CEU certificates for these sessions. If you attend live, you get 1.0 credit for that. If you do the Moodle sessions, it's 0.5. And like I said, let us know if you have any questions about that. It's on our website, envision.unm.edu. Go to online training. So again, join the conversation. You can always use the chat function as well. So you can type in questions and we'll jump in and announce those questions as time permits. Our disclosure and accreditation statements are on screen right now. We're required to have those up in order to offer the CMEs. We do have case consultations. If your patient happens to be a Molina or a Blue Cross Blue Shield, those cases to us. We do have a form for that. It's long, but you don't have to fill out the entire thing. Don't be intimidated. You can be reimbursed up to $150 from Molina, and I believe it's about $75 from Blue Cross. So it is worthwhile and underutilized. So please bring those cases to us. So get in touch with us in order to get that ball rolling. And at this point, if you are online here and you have audio, go ahead and announce your name and where you're from, if you would. If you're not able to use your phone or your microphone on your computer, go ahead and chat that into me, and I'll take roll that way. So anybody out there who is on audio?
Jillian Mayer from Tohatchee.
Hi, Jillian.
Hi.
Maria Crawley, Las Cruces.
Maria, thank you.
Stephanie.
And I see Melissa Sanchez from Pediatric Associates in Albuquerque here, and Jennifer Suchon, sorry. All right, great. And I will go ahead and hand it over to Dr. Mason, who will do our introductions today.
I'm Melissa Mason from the New Mexico Pediatric Society, and before I do our great introduction, I just want to thank Kevin Worling and Michelle Widener with Envision New Mexico for continuing to support this effort and doing a great job with it. So thank you, we really appreciate that. I would like to now introduce Dr. Craig Wong. He is the Division Chief at the University of New Mexico Children's Hospital of Pediatric Nephrology and Rheumatology. I actually met him when he was my attending when I was a resident at UNM, and we have continued to keep up with each other through conversations in the parking lot and the frozen food section at Smith's. So this is one of the reasons why he was kind enough to come speak today.
Well, I think Melissa's been great, and I've known her for a long time, and she's been very generous in letting me participate in the New Mexico Ped Society. I just wanted to put a plug in for our annual meeting coming up August 19th. I'm one of the educational co-chairs. So if you don't have your weekend reserved for the Wilder lecture, please put that in now. We're going to be talking about a number of topics, including cardiology. We've got general pediatrics, child advocacy. We're also going to be talking about palliative care programs in New Mexico, a joint program with both University of New Mexico and PEDS. And we're also have Leslie Strickler talking about a few pointers on child abuse so that people don't get out of date, and much more. So we also have a abstract program, and we'll be sending out announcements. So I think we finalized the program, so please watch out for your email inboxes to get the notice, and we look forward to seeing you there. So I want to thank everybody for inviting me to speak today about pediatric hypertension. I think that pediatric hypertension is sort of it's easy to identify, hard to manage, hard to get everything coordinated. I wanted to give like a few pointers. I've got about a half hour's worth, maybe 40 minutes worth of content, and wanted to leave some room for some case presentations and questions with a smaller audience. So we'll be going through a few slides here on kind of what I wish people would know before sending folks to our clinic with hypertension. And then given that we've got a pretty high burden of obesity in the state of New Mexico, there are a lot of things that can be managed first in your office before sending them to the specialist. I think we also have a program here to get out to rural sites. Jane Beckley, who's actually sitting here in the room with us, was one of our nurse practitioners in our clinic, and she's joined Envision New Mexico and their Fronteras program to kind of assist with the management of hypertension and obesity, and so that's a nice 2-for-1. I also think that it's nice that New Mexico, the Envision program, has a telehealth case conference, so if you've got some problem patients and they can't travel, this might be a nice way to discuss hypertension cases in your office. So without much ado, I'm going to head over to my slides. I do research for the National Institutes of Health. I do a couple chapters and up to date, and I have some research funding. So what I wanted to do is just go over the physics of blood pressure. I think it's a curious topic. Everybody wants to know, or maybe some people haven't wondered about how those electronic blood pressure machines work and how they compare to auscultative blood pressure. So I'm going to be talking about the physics of blood pressure and how those machines work. We're going to talk about the trials and tribulations of a general pediatric provider in a very busy pediatric office. You know, even though people make it sound so easy to manage and identify hypertension in a pediatric patient, it's a lot harder for a lot of reasons that I'll go through in the talk. And then we're going to go through some troubleshooting, things to consider prior to referring to a pediatric nephrologist, and then a consideration of patients that might be candidates to be managed in your office prior to referring up to pediatric nephrology, which patients are safe to try managing and which ones may not be so. And so we'll go over some of the differences and a protocol that I worked out with our general pediatric division at the university. So blood pressure in a pediatric patient is defined by an average systolic or diastolic blood pressure greater than the 95th percentile for age, gender, and height. And so it's a moving target as a kid gets older. So the younger the child, the lower the blood pressure is considered to be normal. And as the child gets older and more to adult height, then you start approaching on the adult norms. But there's still some standards that we all know about through the 4th report. We know that pediatric hypertension is a major determinant for adult blood pressure. It tracks longitudinally, and so we care about it more so than they did when we were little kids. So that's why we really go after managing high blood pressure now. And also high blood pressure is an indicator for a number of secondary disorders, including renal vascular disorders, endocrine disorders, or other rare disorders that a lot of people don't want to miss. And then usually with very high blood pressure or higher blood pressure in a younger child, when secondary hypertension's less likely, or secondary hypertension is more likely, we usually tend to think about referring to our cardiology colleagues or renal colleagues. So blood pressure, so we're going to get into some of the physics. Blood pressure is sort of like a direct current circuit And so on the screen, you see that on the right, we have good old college physics or high school physics where we look at Ohm's law. I'm going to get the arrow here. We have a battery, which is acting similar to a pump. It puts the amps through the circuit. Our flow through the circuit is determined by resistance, and it goes. We have an analogy to the flow of water through a system. So whereas in the electric current we had Ohm's law, we have Sou's law here, where force is equal to the change in pressure across the pump and across the resistance. And so this very much looks similar to a heart circuit, where the heart is now our pump, and we have cardiac output putting blood into the arterial system. We have it go through some resistance. We have the capillary bed here. And then as the blood goes running downhill, it goes through the venous circuit. And so in essence, the heart acts like our pump with a change in pressure. And we measure that simply when we look at the mean arterial pressure. It's equal to the cardiac output times the resistance. And so we know that this change in pressure lets blood run down a pressure gradient so that it ends up back to the heart. And so anytime we have a derangement where, say, we have high venous capacitance or we got problems with our pump, we don't have good flow. And so when we're talking about pressure, we're really talking about the arterial pressure at the point, at the maximal squeeze of the heart. That's systolic blood pressure. And then when the heart is resting or refilling, that's diastolic blood pressure. And so the blood essentially runs downhill and then continues through the capillaries. If you have a lot of capillary beds, that kind of reduces the resistance going through those small beds, and then it gets to the venules and the veins. The venules and the veins have the little valves that help assist with pushing the blood back to the heart, as well as muscle contraction. Then it gets to the vena cava. And so when we're measuring a blood pressure, we're measuring blood pressure as it travels through the artery. And so on this diagram, we see a schematic up at the top here where once you inflate the blood pressure cuff, you have the first sharp thud for phase one, and then you have the blowing, whooshing, swishing sounds, and then after the and then after you get down to the diastolic component, you get to more laminar flow. And so the idea of this slide is to show that, you know, when you compress the artery, you have a state where the artery is completely blocked and you have no flow through it. You can't hear anything. And as the artery is opened up, you have more turbulent flow getting through that artery. And then as it opens up, you're going to hear it more and more until the artery's all the way open, and then you get laminar flow, and that's when the sounds disappear. So the first sounds of the steady heartbeat that you hear through an auscultative blood pressure is your systolic, and then as your artery is wide open and you have achieved laminar flow again, you don't hear the pulsations anymore, and that ends diastole. So this is a lot different than, so this technique is difficult to train people on. They're going to hear, sometimes your heart start hearing early sounds, but if it's not a steady heartbeat, then it's not the true systolic. Sometimes people have a hard time hearing through a short cuff, and so you might end up saying that the diastolic's a lot higher than it really is because you're not hearing all hearing the ends of the pulsations. And so it's difficult. And so people wondered how to make this simpler, and now we have this machine. In my lifetime, when I was a student, I saw these machines starting to enter the floor. It seemed pretty easy. You put the cuff on the patient and they gave you your numbers. So it's a very old technique of measuring blood pressure. It was originated in 1876, but then with work done in the NICUs, when you have a direct pressure reading to the umbilical artery and measuring pulsations and correlating it with machines, and the advancement of computer chips, they were able to automate this in the 70s and the 80s. And so these machines kind of run on an algorithm, which I'm going to go through on the next few slides. But first, before I do that, we're going to talk about the elements of the machine. It's got a processing unit, which is a computer chip, and then it's got a computer program. It feeds into an air pump, a control valve, and then a dump valve. So basically, it opens up all the way when it's done measuring blood pressure, and then it's got a pressure sensor all built into one with the cuff. And so any type of interference that you get with the cuff or any mismeasurement of the cuff will result in not an accurate reading. And so we spend a lot of our time trying to sort out whether or not it's real or a real blood pressure, or if it's a artifact based on how the cuff was placed and how the measurement was taken. And so one thing to keep in mind when we're measuring blood pressure, and this happens a lot in my clinic, is that sometimes we don't adjust the machine settings. The machine has preset settings to the maximal inflation pressure, and so there's a toggle on the machine to set it to like an infant max blood pressure, which is in this range, to pediatric to adult. Oftentimes, when the machines are left at an adult setting and you're putting the same cuff on a toddler, some children have pain, and if you inflate to the maximum pressure, sometimes that can cause bruising, and the kids obviously don't like it and they'll squirm, and then after that you won't be able to get a quiet blood pressure on them. So this is something to keep in mind, but it's simple in concept, but very hard to get the training rolled out to your staff. So it's one of those things that we don't have time to talk about training your staff, and I'm sure we could talk about that at a later time, but this is something that if you're trying to troubleshoot, you got to keep in mind. The cuff, after it hits maximum inflation pressure, does a stepwise decrease with the control valve. So as it gradually decreases, it tries to sense the pulsations going through the cuff. And the problem with these machines is that the algorithms are covered by a patent. And so there's no way of really trying to figure out how the machines derive the systolic and diastolic blood pressure. Now on this next slide is a pressure reading of the oscillometric blood pressure. And here's the pressure that's kind of instilled into the cuff by the machine. So you have an air pump that inflates the cuff to the maximum pressure, and then you have the air valve letting out air kind of to set pressures at a time, and then while the valve is releasing air at little bits at a time, it tries to sense the pulsations that go through the cuff in a stepwise fashion. As you can see here, with at 20 seconds, you have a wide amplitude of the maximum pulsation as the cuff decreases in pressure all the way down to 0 or 40. And so if we take this diagram of how they derive blood pressure, the mean arterial pressure is actually correlated with the highest amplitude of the oscillations by the pulse. And so they take the highest amplitude and say that's the mean arterial pressure. And so somewhere in between here and here, they say that we have the middle slope, and that's what we're going to take as our systolic pressure, and then we're going to say that this is our diastolic pressure. And each one of the companies have a different technique in calculating what that systolic and diastolic is. But so between different machines from different manufacturers, you can have them measuring the same map, but they'll come up with a different calculation for your systolic and diastolic blood pressure. But that doesn't mean that we go away completely from systolic and diastolic blood pressure. It's the way the machines are, and we have to know that sometimes when you're getting a funny reading, you have to go validate that by getting an auscultative blood pressure. So this is the gold standard for all the standard tables, is the auscultative blood pressure, and this is just a surrogate to get you in the range of, is the kid normal or not so normal? If it's not normal, then that's when we try to get the gold standard. So let's talk about getting a blood pressure in the outpatient clinic. It's pretty hard because providers are busy. At the university, we have the luxury of having a little bit more time to see patients. In private practice, I understand that the time between patients is pretty quick. Sometimes every 10 minutes, every 10 to 15, you might have 30 patients booked for a day. I think I just had a site visit out in Silver City. Dr. Etheridge definitely has a lot more patients to see in a day, so he has to be quick. And so since you're busy and you have to do all this now new electronic documentation, it's a lot more difficult to spot the kids with high blood pressure. And so their recent study in Journal of Pediatrics that looked at 29,000 pediatric visits at their university, and they had patients where they had both height and blood pressure, and that resulted in around 20,000 visits. 36% of them, in hindsight, had elevated blood pressure, but only 17% of those were recognized. And so amongst those folks, who did better? Well, the general pediatricians versus the specialists showed that the general pediatricians in general did better than, say, hem-onc, ped surgery, otolaryngology, pulmonary, all those. But then when you kind of narrow down the specialists, the nephrologists and those who focused on looking at kids that were overweight, obese, had a 60% identification rate compared to all others. So I think we did a Wilder poster last year taking a look at that at the University of New Mexico. We did a 6-month review of 2 general pediatric clinics at UNM, all kids older than 3 years of age, and those who had a blood pressure in our electronic medical record. We had 364 visits identified, and 164 of those visits met our inclusion-exclusion criteria. And I can say that 20% of them had a diagnosis of elevated BP in the EMR, but overall we didn't do better. So Beecher did a survey. It basically says what I know about our pediatric providers. We want to do a really good job at taking care of our patients, and we want to identify high blood pressure in all of them. But the barriers to identifying it right at the time is not surprising. It involves limited time, and sometimes it's difficult to coordinate care. Sometimes it's hard to refer to specialists, especially if they're backed up. And then sometimes in the moment when you got 5 siblings also in the room, or you're doing a 2-for-1 visit with the family, you may not see the blood pressure at that time. I've been guilty of not seeing elevated blood pressure in a kid when they come for congenital hypertension or congenital hydronephrosis. Only in hindsight, after I'm typing my note, do I see that. And so we take the time to bring the kid back or have the PCP follow up. Thanks for all you that helped me out with that. And also, now that more and more of us are using electronic medical records, we have our medical assistants put in a blood pressure in the chart, but the system that you may use does not flag the abnormals to help you out. So, 17% of people taking that survey identified that electronic medical record was a barrier, but they didn't specify what kind of barrier they had. It could be that you're just so busy doing your medication reconciliation that you don't notice it until later. But suffice it to say, there are a number of challenges in identifying high blood pressure in a child in a real life clinical practice. So it's also difficult because the blood pressure tables that you have available to you are difficult to read. That's my opinion. I mean, you know, this is our current guideline. I mean, this is not changed since 2004. So this article is like 13 years old. I mean, it came out right when, you know, I started my job at the University of New Mexico, and it's been the standard ever since. But when you take a look at these tables, you got over 600, you know, values to digest. And who's got the time to take the blood pressure of the kid of that day and then kind of marching it over on the table and then, you know, kind of making sure that the child's okay. So for example, if you got a 4-year-old who's got maybe some questionable blood pressure, you have to kind of look at 90 at the 95th percentile, and then you gotta kind of have to match it up. And what happens if you only have one reading they're high? Well, you got to bring back the kid another day to verify if it's truly elevated. So what people have been doing since the publication of the guideline is that they've been trying to find a way to help out general pediatricians by making it simpler to identify blood pressure ranges that are not normal. And so this is a simplified table by only taking the 5th percentile of height and age. So you're shooting low in order to kind of capture all the kids that might have abnormal blood pressure. It helps improve the recognition of high blood pressure, but still that's still a lot of numbers. And so in 2011, we have this table. I find that pretty helpful, but I've been doing high blood pressure work in kids for a lot of years, and I just have internal numbers in my head. And so this is what I use. I use infants, 90 to 50, you know, it should be higher than that. When I get a child that's 100 over 60, I know that's a high blood pressure for the baby. Toddler, I use 100 over 60. So anytime I get 110 over 70, that's high to me. And so I go back and I make sure that we're getting good readings. School age, 110 over 70. And then in teen, you know, more or less if they're 120 over 80, that tends to be high, unless they're like huge football players. And then that's another set of issues that we'll talk about in the end if we don't have too many questions. But so those are kind of the guidelines that I use, and then, you know, if a kid's kind of above those in that range, I go back to the tables. So so we're going to talk about some troubleshooting in the office right now. So so what's better, an arm or a leg blood pressure? And I've got my preferences, but you know, if we're I'd say measuring on the blood pressure on the arm is the way to go, because the standard is to measure the blood pressure on the limb that's at the level of the heart. And the reason why is that our blood pressure in our blood system also is responsive to gravity. And so if you've got measuring a pressure below the heart, you've got the gravity of the weight of blood on top, in addition to the kind of pressure that's within the limb. And so if you measure a blood pressure on a calf of a child and it's well below the heart, you've got the pressure here in addition to the pressure of the effect of gravity of blood onto that limb. And so that's why, you know, you're going to get a artificially high pressure reading if you check a blood pressure on a kid like this, and that's why I recommend not doing that. The other thing to do if you've got a kid who's a toddler and won't hold still is to lay them on the table. And at least you get the leg at the level of the heart, and that will tend to be a little more accurate if the kid's a little fidgety. So So when you have an elevated blood pressure, what do? Well, first thing I do in my clinic is I want to make sure that the cuff is the appropriate size cuff. And so a lot of times people will go based on the labels, adult, child, and infant, but if you open up the cuff, there's internal markings, and I wish I had a picture of one of those. But I think after this talk, we can dig up the YouTube video that Jane did a few years ago. She has an Envision presentation that goes over the cuff size measurement. So I think we'll post that after the talk. But as we said before, the cuff size is important because it's not only, you know, the way to occlude the artery in the child so that you can get the measurement, but it's also acts as a sensor. And so if you've got a cuff that's too small, you're gonna run into problems with what we call undercuffing. And undercuffing is using a cuff that's too small that gives you too high of a reading. We usually recommend going up a cuff size higher so that eliminates this problem of undercuffing. We're not likely to get a artificially lower reading on a larger cuff than we are to get a bad high reading with too small of a cuff. So make sure it was sized appropriately. Whenever I ask my MA, did you use the right cuff? They said, oh yeah, we use the right cuff. But yet I can tell you time and again, don't bother asking, just ask them to remeasure it with a larger cuff size. And if you get the same reading with a larger cuff size, then you know you've got bona fide high blood pressure. So we generally try to get 2 to 3 repeated measures with a larger cuff, you know, when we get a higher blood pressure reading. You may not have the luxury of, you know, having the kid wait around and taking up a room. So if you're in a busy private practice or you're kind of backed up already 3 to 4 patients, just schedule another appointment to come back for the child to get a repeated blood pressure measurement. Okay. Now, in this era of big kids, sometimes 200, 300 pounds, we usually recommend for those patients to have a thigh cuff or in your office, just because oftentimes if the kid's got a big arm and the arm is say bigger than say Melissa's thigh, then you gotta, you know, get a larger size. And I can tell you that it'll help you a lot. And you know, and we can talk about kind of obesity related high blood pressure issues and how to manage those kids at the end of the talk if we have time. But I guess my point is that, you know, if you're checking blood pressures in your office and you got kids that are obese, you should have a thigh cuff handy and be ready to use it to recheck it. The 4th report in pediatrics, they've got this algorithm. I mean, I know some of the authors for the 4th report, and they really try to do a good job and be comprehensive. But you know, they included too much detail, made it too complicated, in my opinion, to go through this algorithm. And so we try to come up with something a little simpler in our office. So I'll blow up this protocol on the next few slides, but we had, going back 2 years, we had a collaborative meeting with our general pediatricians. Nobody really knew what to do with all the kids that were obese and had high blood pressure. And so for a little while, every kid that had a high blood pressure reading just got referred to pediatric nephrology. And we just couldn't see all those patients. So and then we had more people asking us to have a nephrologist on hand for polycystic ovary clinic and, you know, kind of tell obesity is prevalent. The particularly ours, coverages, we just wanted to come up with a consensus recommendation by all the pediatric nephrology staff and what our general pediatricians thought was reasonable. So now, before you decide that you want to do this, you got to have, there's some caveats to using this protocol that who your friendly nephrologist and cardiologist is. And it's not, I'm not just plugging UNM. I think Rob Miller's nice. And, for those of you who want to refer to him, I think he does a great job. And we have great cardiologists in the state, so no matter who you choose, you're not going to go wrong. I think the hard part is not finding a referral service to send to, but the management of these kids, especially those with high blood pressure and obesity, involves dietitians, counselors, involvement with school, changing maybe once, twice a year, sometimes 4 times a year. But unless we get engagement with, the people that are in the kid's life on a daily basis, a lot of times we're not going to be able to get far. And so now, depending on where you live and the resources in your area, these recommendations may need to be modified for what you have available. So I'm going to step you through this. So the top box, you've got 3 different occasions that you have a blood pressure that's elevated more than the 90th percentile. Then the kid has some concerns for hypertension. If it's way more than the 99th percentile, you've got to call your local pediatric nephrologist for a hypertensive emergency. If the measurement is from an oscillometric device, as we said, those devices, they do a good job at screening. I think they're really helpful if you're trying to figure out whether or not a kid's got shock. So if you got a detectable blood pressure and you're using an oscillometric machine on a kid who's dehydrated, any blood pressure reading you get is great. But you're not very good, these automated machines aren't very good for picking out the kids with high blood pressure. So when it comes to high blood pressure, we usually recommend checking a manual. Now, the reason why I say that is that we had a well-meaning resident who was taking care of a child with who was pale and maybe had thready pulses, and they checked the nurses checked a blood pressure, and our well-meaning resident said, "Wait a minute, kids in shock," but they said, "Wait a minute, we need to get an auscultative blood pressure." So I'd say the rules about an auscultative blood pressure only count if the blood pressure is high. If you're dealing with shock, you want that blood pressure to be higher, so it really doesn't matter how you measure it. So I want that to be a takeaway for safety, just so we had an educational moment and everything's good, but I just wanted to kind of put it out there that asking for a better blood pressure only counts for the high blood pressure readings and a kid that's stable. Okay, so now if you get a kid that qualifies, of course, usual med school stuff, get a family history, physical exam. Want to figure out the past medical history. If the kids had a NICU stay, worried about like a umbilical artery catheter clot, that's important. We're finding that more and more preemies are having problems with essential hypertension. That's the Brenner hypothesis, or we have a lot of kids with longitudinal tracking from the NICU go on to have later increased risk for diabetes, obesity, and high blood pressure. And people are trying to piece together why, and that's why we have a National Institutes of Health initiative to looking at health concerns over the lifespan. What are the pediatric or neonatal antecedents to the adult problems that we see? So that's so pending no disasters and funding to the NIH, that's going to continue. And then we usually look at sleep apnea, urinary tract infections, and any other chronic diseases. Like sometimes you get kids that have seizures and absent seizures, and during a seizure, your blood pressure can read high, and then after the seizure's over, the kid's tired, blood pressure goes low. So sometimes we get intermittent blood pressure elevations with petit mal seizures. So you got to just kind of worry about other chronic diseases. Okay, so we usually do a workup. We look at our basic renal studies. Most common reason for high blood pressure, especially in younger kids, is usually kidney problems. We'll also look at urine microalbumin to kind of catch the kids that are pre-diabetic. And then we get a renal ultrasound. That's kind of a good start. If the blood pressure is kind of higher, you're kind of worried about whether or not the kid's got secondary hypertension, or you got these guys, really high blood pressure, and you're the first one to see them, grab a renin and aldosterone. That's really helpful. And then, if the child's got a strong family history of diabetes and high blood pressure, they're overweight, they got acanthosis nigricans, go ahead and throw in a fasting lipid panel, hemoglobin A1C, LFTs to look at potential non-alcoholic fatty liver. And so these are our kind of algorithms here. If it's a child older than 11, yes. If it's no, that kind of goes down the path of referring to a specialist. So if you got a little kid, they get referred. Is the BMI over the 85th percentile or higher? No, that goes to a specialist. If you ruled out secondary causes of hypertension, so creatinine's not 2, and the kid doesn't have abnormal hemoglobin A1C, or they don't have ALL with super thick blood, then you can kind of go on towards some type of office management. Okay, so if you're still in this realm, those kids are candidates for being monitored in your office, because likely they've got metabolic. They're going to do therapeutic lifestyle change, cut out their soda, watch their screen time, get them more active. So have them try that for 6 months with regular follow-up and blood pressure checks. We do have a separate protocol for school nurse blood pressure checks, and they're a great ally. I'm not sure what's going to happen with school nursing support since the APS budget got cut, so that may not be around, but I think while you have a school nurse, or we have school-based health clinics, then that's a possibility. If the blood pressure is unchanged or worsened, consider obtaining an echocardiogram to evaluate for LVH. So if there's LVH, then consider the start of amlodipine. And I'll go over medication, antihypertensive medications in a bit. So, and I'll explain why we recommend amlodipine a little bit later. If there's improvement after 4 to 6 months, go back and repeat, and then hopefully the kid gets better. If there's no improvement, then consider referral to nephrology. We have internally this ad hoc form, but I think for those outside the university system, go ahead and call. And believe me, I think either institution, the University of New Mexico or Presbyterian, can do a fine job for you, depending on the patient's insurance. So, in summary, the workup focuses on excluding those kids at higher risk for secondary hypertension. The younger kids, the kids that are skinny, and the kids that might possibly have a history of renal disease or damage. We're trying to get those screened out and sent on to the nephrologist. The kids are going to need to have some blood testing to screen for metabolic syndrome. We can't just go based on blood pressure alone. The testing kind of helps us out when we're certain to see the child. But realize that elevated BMI does not alone preclude from secondary hypertension, because we've had our share of kids with renal artery stenosis that have hypertension discovered on the ultrasound, and it's helpful to document elements of metabolic syndrome. So I know I'm running out of time. I'm going to remind, so trying to get to treatment, we have this relationship of mean arterial pressure, cardiac output times resistance. And so this is basically blood pressure. And so the mean arterial pressure is comprised of cardiac output. As you remember, cardiac output is comprised of both stroke volume and heart rate. And then stroke volume, you have preload and inotropy for the cardiac muscle. And preload really depends on blood volume and venous compliance. And so, if I have an increase in systemic vascular resistance, usually from renal arterial disease or kidney disease, we'll consider ACE inhibitor, or angiotensin receptor blocker, we'll refer to those as ARBs. If we're looking at increased inotropy or increased heart rate, we've got beta blockers or alpha blockers or mixed. And then, quite often, the most common reason why we have inpatient hypertension is from very aggressive IV fluids, or maybe the kid's got a high salt diet or whatever. So we'll take a look at that, and if we have a history of increased weight and blood pressure going up with that with IV fluids, we'll talk about a vasodilator or if need, diuretics. So note on obesity and hypertension, that really doesn't follow any of the usual pathways that you learned in med school. So when you have excess adiposity, the fat cells put out what we call adipokines. We used to think that fat cells were very passive, but now we realize that they secrete a number of cytokines and hormones. So in essence, the increased fat cells increase your insulin resistance and your leptin. It goes down these kind of second messenger pathways that I'm not going to get into, but it goes to say that these hormones secreted by the fat increase your lumbar sympathetic nervous activity, and leptin also increases the renal sympathetic nervous system activity, and then that all leads to hypertension. And so so that's the mechanism. Usually, if you have increased activation of the renal sympathetic nervous system, it causes a release of renin and aldosterone. So since you have renin, aldosterone, and angiotensin system activation, a lot of those kids we end up putting on an ACE inhibitor. So we also recommend kind of limiting their salt in their water, and so sometimes you'll see when a child's come to see us and we've diagnosed them with metabolic syndrome and hypertension, we'll put them on an ACE inhibitor, and that's kind of what we do. Oops. So let me, okay. So kind of in summary, with obesity and hypertension, we do all this. We usually start the calcium channel blockers or ACE inhibitors. Let me see. So the reason why we choose calcium channel blockers over ACE inhibitors, calcium channel blockers are safe. They can be easily made into a suspension or liquid suspension. We don't really have a lot of side effects on the electrolytes, so we don't worry about hyperkalemia or slight increases in their serum creatinine. The one thing I've noticed about calcium channel blockers, every once in a while we'll get a child who gets a little bit of angioedema with some swelling in their legs, but usually that's associated with a high salt diet, so they might not have cut back on their Takis or their hot Cheetos. And the ACE inhibitors, they work great, but you got to do blood testing to screen for side effects of hyperkalemia. Sometimes you get a kid with borderline kidney function, or they're dehydrated and they can get an elevated creatinine. And, if you don't want to mess around with kind of bring the kid back for, blood checks on a regular basis, or worrying about hyperkalemia or impaired renal function, the calcium channel blockers are very safe. So anyways, I want to thank the New Mexico Ped Society for inviting me out. So Melissa, Brian, the Education Committee, and Vision New Mexico, and then all y'all who refer to pediatric nephrology, and especially I want to thank our patients, families, and our trainees who are now out in the community. So I think we've got some, sorry, I talked a lot. I've got some time for questions. Anybody have a question?
And feel free to unmute, or if you're only able to chat in the chat box, that should be popping up there for you as well.
Well, I have a question.
Sure.
You said that you would get back to the dosing for the amlodipine.
Right.
How do we, if we're going to start a kid?
Right. So if you're going to start a kid on amlodipine, the usual starting dose is 0.1 milligram per kilo per day. I think we usually march up in 0.2, 0.3, 0.4, but we have round numbers of what we use. So eventually, we kind of start rounding up to 2.5, 5, and 10. Anytime you're getting up past 10 milligrams on a child, you got to start worrying that this is not effective, and maybe we should consider referring to someone that does this more often, or consider rechecking your automated blood pressure equipment. But I think usually, if the child's still gaining in their BMI and the family hasn't made any changes, then that's usually time to get some expert help. And we have very good people that do obesity management. We have, I think right now we have Sylvia Negretti, who's doing the Healthy and Fit Family Clinic, but I think it'd be nice for her to get out here to do a PEDx talk to help with some of the key things on motivational interviewing. So I know I didn't cover a lot. I mean, we got renal arteries, hypertension, we've got, glomerulonephritis that can cause high blood pressure. We got pheochromocytoma, neuroblastoma, all those things. I think anytime you're thinking that a kid's not right and may have one of those things, that's something that you probably need to consider referring for. I mean, I think for pheochromocytoma, usually there's a malignancy or a mass or something like that that triggers those hormones, and those kids are usually toddlers or school age. It's going to be quite rare that you have an undiagnosed Wong's tumor these days that cause you to have hypertension, and it's not often that you're going to be measuring a blood pressure on an infant. So usually those kids are picked up on kind of the prenatal screening or a good physical exam, palpating an abnormal mass in the abdomen for an infant. So like I said, most of the problems that you're going to be seeing are with blood pressure, kind of measurement technique errors for kids with obesity, but any kid outside of that, we're always a phone call away, and call any of us to the physician access line.
We do have one question from Anne-Marie Parmenter. Is it possible to receive a copy of the school nurse protocol?
Yes. So we'll.
Is that something we can send out to our
participants? I got to get permission from our colleagues, but I think Jane had originally written the kind of a version of instructions for the school nurses. So and I got a copy of that. So, anyways, I can let me make sure that I'm not crossing any lines here, but basically it is a note asking the nurses to check a blood pressure at school and to call your office to kind of keep you in the loop, so you got a record of what's happening out in the community. But I'm happy to get something out there for you.
And I do have a list. This is Kevin again here at Envision. I do have a list of everyone here who had signed up and who has attended. So if that's something that we're able to get from you, Dr. Wong, that's something I can help facilitate with. We also have one more question. The video you referenced about the blood pressure measurement that I know Jane Beckley has done a couple of times here for us at Envision. I will see if I can find that. We did lose many of our videos after Adobe Connect, after we lost our license there, but I'll see if I can dig one up, and we'll see what we can do about that.
You got a copy of one on YouTube.
You've been able to find one?
yeah.
Okay.
Yeah,
Okay. I was just looking for it
I'll
and I
dig it
wasn't
up and
able to
I'll find it for you.
find it
Okay.
like that, but it's got to be out there somewhere.
Oh, yeah.
So, yeah. So thanks for those questions. We do have a couple more minutes.
I have a quick follow-up question.
Yeah.
To the amlodipine, when you're starting a child on dosing for that, do you have to dose them in your office and make sure they don't drop too low, or is that you just tell the
Yeah.
parents keep an eye on that?
So
for 30
usually,
minutes or-
you know, the kids that you're going to see are going to be adolescents. And I think for the adolescents, the starting dose of 2.5 or 5 milligrams won't be too low and you won't bottom them out. So if you think about your overweight adolescents, they're going to go way beyond, you know, what the dosing per kilo are. So I kind of gave you the guideline of what we use, but as with this cohort of kids that you're going to be potentially managing, they're well beyond, you know, 50 kilos. So you're going to be dosing them on the low end anyways if you choose 2.5 or 5. And that way you're going to be feeling more like an internal medicine doc that, you know, one size fits all. Usually we'll try to, we kind of max out at 20 milligrams a day, like 10 milligrams twice a day. The other thing that we found of, quote, the medicine's not working is sometimes, well, we usually say medicines work better when you're taking them. So we'll do a medication refill pickup review with their child's local pharmacy. And if there's been only one pickup after the last time we saw them 6 months ago, then you know that, you know, the patient and the family are not engaged in the medical prescription you gave them. So that's another trick that we've kind of learned over the years. Jane calls it loaves and fishes. You know, somehow that one bottle multiplied itself over the past 6 months, and it kind of lasted that long. So I want to thank everybody for listening in and participating. I think if you got any questions or definitely if you got any patients that you want to talk about, please contact me. I think my email's kind of listed with the program. Maybe not. If not, I'll get that out to you.
I don't have it up here. You can always get in touch with either, you know, Dr. Mason or
Michelle.
Michelle, M.I. Widener at salud.unm.edu, or K Werling, K-W-E-R-L-I-N-G, that's me, at salud.unm.edu, and we'll pass on any questions you have.
And then obviously you can call the PALS line, 505-272-2000, and you can get a hold of any of us. Thank you.
Absolutely. All right, thank you very much. And we'll be signing off here and going mute. And please let us know if you have any questions or if you want to sign up for any of our future sessions. Go to our calendar. We did have a question about the PowerPoint presentation as well. That is downloadable from our calendar, and I just typed that into our chat. Go to our website, envision.unm.edu, to the calendar, and you'll be able to download anything you need there. Any questions you have, go to our staff page and talk to Michelle or myself. Thanks again.
Everybody.
It was He basically, the take home is that when they're taking blood pressures from the robo, that he says robos are fine as long as it's not elevated, but to check to make sure that it's on the pediatric setting, because there's different settings, which I actually didn't know that because we never used robos at the other clinic. So he said that there's and to make sure